All right. So, hey guys, welcome to this episode. I am Gwenny. I'm the Director of Education here at Impact EMS. And then I also have Christina with us. She is one of our critical care instructors, but she's on shift today. She flies for, we won't say who she flies for, but she flies somewhere in the Midwest. And as there always is in the Midwest, there's crummy weather. So she can't fly right now. So we were just texting back and forth. And I said, hey, you want to hop on Zoom? And we can record something specifically to our nurse friends that are either looking to fly or maybe just started flying. So, Christina, you want to introduce yourself, even though I kind of already did, and give us a little bit of your background?
Yeah, so my name is Christina Philpott. I have been flying now for 6 years. My background is that I started as an EMT at the fire department, couldn't decide if I was going to be a medic or a nurse, and was like, signed up with my partner to go to nursing school together. He was a medic. Once I finished that, I worked in the ER and then ICU in level one trauma centers and CVICU. I have done travel contracts. I've worked in a 6-bed ER or a 50 plus bed ER and specialty type centers. So lots of different background before I started flying. And I didn't start flying until I was at least 5 years into nursing. So been nursing about 12 years now.
Excellent. So I think the combination of a medic plus an ICU nurse makes a flawless flight crew, which a little bit hurts my feelings to say because my background, I am an ER trash panda, right? Like
Yes.
ICU nurses are prim and proper and things are always organized and perfect. And we are just raccoons in the ER, right? I put a post up on Facebook a couple of months ago. I still work PRN. I still fly PR. I'm full-time here at Impact EMS. I fly PRN and then I work in the ER PRN because I don't want to ever lose any of my skills or knowledge. And I don't want to be teaching things that I'm not still doing. But anyway, the first thing that I do whenever I get on shift is I always grab a thing of purple top wipes and I clean everything
Yeah.
in my domain, the phone, the keyboard, the counter, the chair that I wipe everything down because we're just the epicenter for germs, right? Well, anyway, I walked in and I grabbed the purple top and I always flip open the lid and then use the lid as a handle to rip the whole big part of the lid off, right? Not just the tab. Well, I ripped the tab off from the lid and I was like, what a Gwenny thing to do. I'm always like wrecking things. And then I was like, this would make a really funny post. So I took a picture of like one with the lid and the wipies coming out the top all prim and proper. And then one like I had it. And I was like, this has 100% specificity and I can't remember what the other word is. What am I trying to say? I always forget it. Anyway, 100% reliability for separating ICU nurses from ER nurses. And the comments just blew up and people were like, if that's not the doggone truth. ICU nurses were like, don't you dare rip that lid off. And us ER nurses are like, we don't have time to thread them through there and pull them out one at a time. Nah, you just pull out 6 feet at a time.
Totally depends on where I'm at, what I'm doing, what type of patient I have, because I am weirdly a combo of both. It depends on what environment I have been put into.
Yeah, yeah. But I think that the ICU nurse, there's too much overlap between
Mhm.
Sorry, my stool has a little like knobby thing and it's hitting me in the calf and driving me nuts. The ER nurse, there's a lot of overlap between street medics and ER nurses, right? We work really well together because we think a lot alike. But the beauty of the ICU nurse teamed up with the medic is that you bring the prim and proper and the detail oriented stuff together with their speed, quick thinking, ability to adapt, make decisions very quickly. And it's a really nice pairing. So with that said, if that kind of leads us into the first point I wanted to talk about is that if there are nurses out there looking to get into the flight world, I would recommend getting ICU experience,
Mhm.
which is super critical because I do not have ICU experience. I did work at my first ER that I ever worked in right out of nursing school. We boarded a lot of ICU patients. Like we'd hold ICU patients for 3-4 days. So I got ICU-ish experience, right, in managing these patients. But I think it's really good for ER nurses to get some ICU experience before they move over to flight. Would you agree with that? Or would you say they're
Absolutely.
well equipped?
No, I would say I'm very thankful, and I always try to encourage other nurses that are going to be going into this or just starting into nursing. Like, I want to fly. I always encourage them to get both. Here where I fly, I can actually fly. I did a PHRN, which is a paramedic course. So I am a paramedic in this state, but also a nurse. So I can fly dual seat, which we fly medic nurse at my company. But the greatest thing about it is having that pre-hospital experience for scene calls versus depending on where you fly, it could be every state is different of what is your mix between a scene call or a transfer. And I'm at a service right now where I sit at a hospital. So I get a lot of transfers, but also a lot of scene calls. And so having that ICU experience on those sick intubated patients, because they're only transferring them until they're like right about to sign the death certificate, they want to send them off to someone else, that you have that ability to continue on somebody with 6 strips, manage their care, manage their ventilator, and understand all the complexities of the patient going on, because they usually have multiple medical problems where trauma, I feel like, is simple. It's like stop the bleed, plug the hole, make sure they're breathing, and then get them somewhere quickly. So it's kind of nice of taking that. Yes, we're in a hurry, but I have to do things right by my patient and make sure everything's right before I start this transport so my transport can go smoothly. Because once I put them in the helicopter, I don't have a bunch of extra hands or resources that I would if I was inside the hospital.
Yep. And I think a lot of times that's where the ER nurses, a light bulb moment happens and they're like, holy crap, I have been sometimes critical of medics, right? So I defend medics to the
Mhm.
team when they bring in a patient and an ER nurse gets sassy, like, well, you could have started at a second line or you didn't get a sugar. And I was like, sis, watch yourself because you have no idea what it's like to be in a small vehicle. You're right. We bring them into the ER. We've got a bazillion hands. We've got
Yeah.
many square feet. We have lots of room, all the equipment and supplies we could ever need. And that's not the case. But you bring up a good point. My best friend Valerie taught me, we call that a well-lit scene flight.
Yes.
You go into one of those maybe under-resourced facilities and you get a patient who is about to sign the death certificate. It's a well-lit scene flight because sometimes you have to start from scratch.
Yes.
And remanage everything. And those are oftentimes when you learn like, oh no, I have been this ER nurse
Yeah.
trying to send this patient out a hot mess, right? Or
Mhm.
sometimes we show up at a hospital to pick up a patient and it's like, somebody turned on the light in a room full of cockroaches and they scatter and they're gone.
Yes.
And you're like, I need some help moving this patient over to the flight sled. Like, come
Yeah.
on.
They're like, help has arrived. We can stop now. And I'm like, no, I need you.
Yeah. Right. Because we avoid what we're afraid of, right? We've all done
Yeah.
that in the past, right? There have been times where we've had a flight where we've managed a really sick patient. You get to the sending facility and you yeet them to the ICU bed and you GTFO, right? Because you're like, whoo. So we kind of sometimes will do the same thing. All right.
Yeah.
So if someone is looking to get into flight or maybe they're new, what are some things that we could expect? What's the learning curve like?
I think one of the biggest things that I talk about nurses with that they struggle with when moving from inside the hospital to a provider outside the hospital is just thought process. Like you get an EKG in the hospital and you hand it over to a doctor. No, ma'am, like, or sir, you're going to have to read that EKG and then you're going to have to determine what do I need to do? Yeah, we have guidelines and things that we can work off of, but I'm not picking up the phone every time and calling my medical control to say, hey, sending them a photo and saying, what do you want me to do? It's being able to critically think and interpret things that normally you would have left all of those responsibilities onto a doctor to make that decision for you. I think in ER nursing, you have a general understanding of lots of different things, but you don't understand maybe all of the lab values or some of the medications that we're giving and why, or the dose ranges, because you get told start this and then you get to send them off to the ICU or you're transferring them out to someone else that can then titrate it. It's that process of kind of taking on all of that responsibility and really understanding the patho behind why you're doing what you're doing and then being able to make the decision. A lot of times when I orient new nurses to the aircraft and I'm sitting medic seat, it is that, so what do you want to do? And they're like, yeah, it's up to you. Like you have to figure out what your game plan is and come up with all those differential diagnoses of why am I doing what am I doing?
Yep. I think you're right. I think that's the two of the biggest things that I struggled with when I transitioned to flying. And I started flying. I was barely over, I was a few months over my 3-year mark, right? I thought that I was going to get some good interview experience and figure out where I was weak and where I needed to get stronger so that I could fly in a couple of years. And they ended up offering me the job. And I was like, are you sure?
Mm-hmm.
Right. So the biggest areas where I struggled was that I was a good ER nurse. I was good. I wasn't fantastic. I was only 3 years in at that point in time. I was good. And so I thought that I would be a good flight nurse, but I was starting at ground zero, right? And it wasn't the same. Being a nurse on the helicopter, worlds apart from being a nurse in the hospital. It was like you texted me, drinking through a fire hose. The learning curve was huge. And the onus is on you. If you want to start flying, it's on you to learn this stuff, right? In nursing school, they don't teach us at all how to read an EKG. They're like, if there's elevation, this means a STEMI. Okay, well, actually, that's not always true. It could mean many things, right? And sometimes the depression could mean a STEMI. You know, we have this thing called a posterior, right? And it's on you to go and learn all that stuff. I had one friend that was looking to fly about the time that I started flying, and she went and she just audited a medic cardiology course. She went to the community college and just said, hey, like, I don't need the credit hours. Like, I don't need the grade. I don't need to take the test. I just want to learn the information. And they just let her sit in the class, and she went a couple times a week for the entire semester, and she learned how to read EKGs, seeking out education. You know, what a time to be a pre-hospital provider. There is so much available, free resources. You know, Crunch with World's Okayest Medic podcast, he just started his own YouTube channel with free education. Dr. Salim Rezai, he is our medical director. He has a free YouTube channel where you can learn all kinds of stuff. Podcasts, social media, right? We have our Impact EMS medical education page that's free, and we post case studies and all kinds of stuff. There are resources for you to be able to learn it now. You may have to pay a little bit of something. You could take our flight medical provider course where we have, you know, a 3-hour cardiology module that teaches you how to do it, but it's on you to figure out the areas that you are weak and to learn that information, because you will have weak areas. It's not if, it is what are your weak areas.
Yeah.
Right. So if you're coming from the ICU, what would you say are the weak areas for nurses?
The ER stuff, that quick down and dirty, unless you're going on a lot of rapid responses in the hospital, a lot of times it's that, oh crap, what do I need to do right now? It's almost that triage that you get from ER where somebody walks in the front door and you just got to have that look on them and you don't have a diagnosis. It's assessment of that patient and what are the things that are going to kill them right now, and what do I need to know in order to fix them.
Yeah.
That's where they struggle, because they already have like a plan of care kind of established for them. They already have all the answers, and then they get told these are the X, Y, and things that you're going to do, versus in the ER, it's like a free for all and you have no idea what's about to walk through that door. As an ICU nurse, I have, oh, you're going to get a respiratory, failure patient coming up, and you can have a little bit of time, hopefully, to get all your things straightened up and ready and make sure your suction's good and all that. And in the ER, it's a completely different world. Same thing with pre-hospital.
Yeah. Yeah. Even as an ER nurse, scenes, I did not know what to do on scenes. I was like,
what do I do with my hands?
With my hands, right? And I had a great medic partner who he just said, just follow me. He said, just stay right on me and just do what I do. I gotta sneeze. Maybe not. It's harvest season. I don't know what time of year everybody's going to be watching this video, but it is harvest season right now. And Nina and I have both been texting each other last few days, like, are you dying today? Yes, I have sneezed 486 times since waking up 1 hour ago.
We have actually gone IFR because of all the corn dust.
Oh my gosh.
Meaning that it's so dusty outside from all of the harvest that you can't see outside to go fly.
Yeah, it's wild. Anyway, sorry, scene management. So one thing that I would recommend, whether you're an ER nurse or an ICU nurse, is go get your EMT and get some ride time, right? Get a PRN job at some agency somewhere and just get some ride time in and get some reps in, knowing what it's like. It's going to help you for 2 reasons. Number one, it's going to help you to not look like a dummy when you get on scene, and you're going to know what scene management is like, right? But also it helps you understand what it's like for the ground crews. You know, all of our scene flight calls, we rendezvous with a ground crew. I have only maybe once in my flight career beaten the ground crew to the scene, right? Usually they're always there first. But when we do things like auto launch, and this is stuff that if you're a nurse and you've never been in the flight world, you're not going to know what we're talking about. Auto launch is when a dispatcher takes a 911 call and they're like, oh, the caller says, oh my gosh, there's this terrible pileup on the highway. There's all these cars. There's people like moaning for their lives in the car. The dispatcher knows, like, hey, this person is probably going to need flown. So they dispatch their ground crew, but then they also call the flight crew and dispatch them as well. so that we don't have to wait. There's no delay in the ground crew getting there and going, ah, snap, this person has one foot in the grave and the other on a banana peel. Let's get a helicopter here. Now, if they dispatch us both at the same time, we're going to be almost there. So it's going to be good for you to understand what it's like for these ground crews whenever they call you. It is going to build your ability to establish rapport with them very quickly. You're going to know what it's like inside the back of the ambulance, because no matter how good we are in the ER recess bay, we have no idea what it's like to be in an ambulance, right?
Right.
So those things are good. And I will say, I probably shouldn't be letting this cat out of the bag, but forgiveness is easier than permission. But we are going to be offering an online nurse to EMT bridge here at Impact EMS soon. Now, there will be a skills portion that you've got to check off. That part will have to be done in person as well. We're going to offer it to agencies where we will send an instructor to your site. Like if you hired, 10 new nurses and you want them all to have their EMT, we can come and we can do that in just a couple of days' time. But I would highly recommend getting your EMT as well. Some states require it. I know Arkansas, I used to have my EMT and I, like an idiot, let it lapse.
Tennessee is another one with my company. If you've been flying at least a year, you have to get your Tennessee EMT.
Okay, so that you can go and cover there.
Mm-hmm.
Yeah, because it's just such a good idea to know what it's like for the ground crews and have that experience. So to sum up kind of what we've covered so far is it's drinking through a fire hose. Your learning curve is going to be huge. If you go in there thinking like, I'm a great nurse, I'm going to transition quite easily. Pride cometh before a fall. You're going
That's the big thing, is like understanding every single person that started in this job. They're like, yeah, I'm just going to do the same thing and go to a different section. And then you're like, holy cow. And every single person, whether you're a nurse or a medic, and it doesn't matter how many years under your belt that you have, feels overwhelmed. And that is totally normal to feel completely overwhelmed.
Yeah. I'm sure everybody here is familiar with the Kruger-Dunning effect. If you don't, pause the video and go Google Kruger-Dunning effect, right? So it's a graph. Your x-axis is knowledge and experience, and your y-axis is confidence. And so what we see is someone gets a little bit of knowledge and experience and their confidence goes way up, and they're like, I totally got this. Like, I'm a good ER nurse. I'm a good ICU nurse. I have 3 to 5 years experience. Like, I'll probably be pretty successful in this job. And then they get a little bit more experience on the aircraft, and suddenly their confidence drops like a rock, right? They're like, oh, I don't know anything. I distinctly remember learning about ventilator management.
Mm-hmm.
And I knew more than most of my peers in the ER about ventilator management because that was something I wanted to learn about. So I was always asking RTs, like, teach me this, teach me that. But when I learned really how to manage a vent by myself without calling RT, I was like, I have killed so many people in my life.
Yeah.
Right. And I see that when I go and teach the FMP, the flight medical provider course, it's usually day 3 is where everyone's chin begins to quiver. It's usually day 2 for the medics because we talk about the lab values and they're like, I'm just going to go water flowers at Lowe's. Like, I'm done. I can't do this. For the nurses, it's day 3 when we cover cardiology. I like see the tears well up in their eyes and they're like fighting, like, don't cry in class, don't cry in class. I've literally had students burst into tears in class, right? Men and women. And they're like, I can't do this. It's too hard. It's too much. Or I've killed so many people. Or I'm thinking about this patient that I took care of one time that I did it all wrong, because you didn't know what you didn't know. Mm-hmm. And now you know, oh my gosh, I was doing things all wrong. And I see that quite often. And I went through that process myself in going, oh, I did really bad. I'm not the nurse I thought that I was. So I think it'll help people just to hear you and I talk about this. If they're going through that stage right now, like, take heart. It's okay.
Yeah.
Now you at least know where you know what you don't know. And so now you know how you can fix it, right? The first step is realizing that there's a deficit somewhere that you need to fix. So don't get too discouraged. Some fear is good, but don't let it paralyze you.
Yeah.
Be scared to keep trying. Excuse me. Sorry, my allergies are murdering me. All right, I'm looking at your list of all the ideas that you texted me about things that we want to cover. Oh yeah, pulling the trigger on decision making. You kind of brushed on this earlier, but expand on that a little more.
I think one of the things nurses struggle with is there's so many options, and normally they're being told what the answer is or what their course of action is going to be. And when you get there and you have that hypotensive patient and it's you and your partner and you don't have a doctor to reference, you have to decide, okay, why is my patient hypotensive? What do they actually need? Do I need to like cycle that blood pressure one more time and like see if it spits out a better number? Or should I go ahead and mix levo? Or you could be like me and then I mix levo and I just ward off evil spirits and dangle it over their bodies just
Yeah.
in case,
Yeah.
because you don't want them. You're like, they could start going down that way. The amount of times I've picked up cardiac patients that have like a lot of PVCs or they're a STEMI and they start throwing PVCs, and I will put amiodarone in my pocket ready to go just in case, has saved me because my patient went to beat the breast mid-flight. And it's things like that, is knowing like I might need this. It's better to have it right here versus going, oh shit, and then
Yep.
cycling through the bag and going, I need this right now. And then you're trying to rush and do it versus preparing yourself beforehand. But it's pulling that trigger of, do I need to start blood? Do they have a positive shock index, which is a sign that they need resuscitation of some kind? Where am I at airway wise? How much, what is that trigger point that I'm going to be like, we need to go ahead and take this airway? Or thinking about that clinical down the stream, like, what can I do so that maybe if I give drugs now, maybe I won't have increased ICP. Maybe they'll have better ventilator compliance, or taking the time to adequately sedate and give pain medicine to your patient before you start that trip. Just kind of
100%.
putting all those pieces together, but it's pulling the trigger to be like, that's on you. You have to decide what is that point that you make that decision.
Yeah, absolutely. 100% agree with. I do that with patches, fast patches. If I even think they're thinking about coding, I'm like, I don't trust you any further than I can sling a piano. You're getting fast patches.
Every STEMI gets them for
Yes,
me.
every STEMI and anybody who has a 1 foot in the grave and the other on a banana peel. And it's not that the nurses don't know what to do, right? It's not like we have to run to the doctor every time and go, oh no, they're having nausea. What shall I do, doctor? Right? You
Mhm.
already know. What you do is you go to the doctor and be like, I already pulled it from the Pyxis. Can I give it 8 of Zofran? Yes, you can. Okay, good. Sounds good. Or the ER nurse, they're already grabbing the levo. Hey, doctor, you okay if I start this levo at 5 mics a minute? This patient is hypotensive and they're going to crump. Yep, that sounds good. It's that they're scared. We tend to be scared to make the final decision on our own. That's where medics are so good, right? They make
Okay.
decisions all the time, right? They make
It's just
decisions
them.
very quickly, right? It's like a husband and a wife. The husband's like, where do you want to eat tonight? I would like to eat it XYZ, and they head that way. Whereas, the nurses were the wives, like, well, I don't know. I was kind of thinking about maybe a salad from McAllister's, but then kind of maybe soft crab, right? Same thing.
Yeah.
We got to think about it and for a bazillion years. And it's not that we don't know what to do. It's that having the onus of being the decision maker or having their name on it, right? There's a bazillion times where I'll do something in the ER and I tell the doctor, like, hey, I'm going to do this. I just need you to put the order in.
Mhm.
Like, there's nobody, it's on you. If this order goes sideways, it's on you. And I think that's where part of it is. Sorry, I have so much. Speaking of suction, I feel like I need to suction myself right now. I got so much snot in my throat. All right, next topic, when to go versus when to stay and play. I wish there was another term for stay and play because I hate that term, but
I know there's like,
we're not playing, right? Somebody's life in our hands.
exactly. I think it's such an important topic because you have to think about what is going on with your patient. Is this somebody that, depending on what is wrong with them, I need to get X, Y, and Z done before we start this transport to, get their oxygen up, to secure an airway, to make sure that I've controlled bleeding before I put them in the aircraft and I don't have maybe as good of access, or having multiple IV lines and I have decent access before I get them in the aircraft. Because I mean, there's all sorts of different airframes out there. What ability you have to get to your patient, even in the back of an ambulance, kind of shrinks down once you put them in a moving object in the middle of the air going in a certain direction. And it's what is going to matter right now, or I can't fix all the things. We need to get to the cath lab. We need to get to a surgeon because I only have 1 unit of whole blood on my aircraft. I do not have mass transfusion. I am going to fix you immediately, but I know that time is money right here. And I need to get you to the surgeon or to mass transfusion in order to save your life. And it's trying to figure out what is best. Like they have shown that in pediatric cardiac arrest, it is better to stay and play because you have better outcomes for your patients. However, in trauma, if I can have a trauma, strokes, STEMIs, things like that, if I can get them to definitive care to get that clot taken out, to open that vessel back up, or to get them to the surgeon to fix their bleeding problem, they have better outcomes. So it's making that decision of what type of patient this is, what do I need to absolutely have to do before we go, and then just getting to where I need to, because I am truly not definitive care. No aircraft is. The definitive care is a stent, getting a thrombolectomy where they're taking that clot out of the brain or opening them up and clamping off whatever is bleeding.
Absolutely. Great point. As a matter of fact, I got criticized in my last sim for doing this, for staying on scene too long. It was a patient who had a GI bleed, and I wanted to start blood in the ER before we took off in the simulation. And you know, we walked through the sim, and my medical director let me finish it, and then he said, "Why did you start the blood right here?" And I said, "Well, because the patient needed it. Like she was crumping right before our eyes. She needed it." And he said, "Well, she was already on a vasopressor. Why didn't you just amp up the vasopressor and then throw her in the aircraft and start the blood in the aircraft?" And I was like, "That's a good point." Because he said, "You're not going to fix her right here in this ER. She needs to get to the OR is her definitive care." So sometimes just a temporizing measure and then getting them on their aircraft. Now, that's not always the same for you and for me, right? Because we fly in two very different airframes. Are you in a 206 or a 407?
I'm in a 206.
A 206. My friend's, her 206 is about the size of this can of Diet Coke. And I actually used to fly for the same company as Nina. We didn't know each other because we were like 3 states apart from where we were flying. I have flown into 206, and I practice differently in that airframe than the airframe I fly in now. I fly in an MD 902, which is about the size of a dump truck. I can literally do a somersault in the patient compartment of the aircraft. It is so large. So there are a lot of things I could do in that aircraft that I couldn't do in a 206. So there are things that Nina might do on scene at the well-lit scene flight at the sending ER, right? She might fix that I might not have to. So we can't give you the answers of like, this always needs to be done. Like Christina needs to make sure that I used to fly in a 407 at the first company I flew for.
Yeah.
We always make sure we had a right AC or a right upper arm IV, because that's really the only access you're going to be able to have with your patient. In the airframe that I'm in, I'm okay if all they have is a tibial plateau IO, because I can give meds through that. I can reach my whole patient. So the answer is not the same. For everybody that's watching. It's going to depend on your airframe. I know that the company that you fly for also has some 130s in your fleet. You have fantastic patient access. Matter of fact, I'm friends with somebody else who flies with your company, and their base just moved into a 130. And he was telling me, you know, my 130 is coming. I said, "You're gonna love it." And
So
I got
for activities.
Yes, that's exactly what he said. He texted me right after they moved into it. He was like, "This is amazing." I'm like, "I told you, it's fantastic." So it very much is dependent upon your airframe. And that brings up another point. When I first started flying, I knew nothing about aviation. Like literally, I had never even been in a helicopter. I asked them when I was interviewing, I was like, "So can you like take me for a spin? Just to make sure I'm not gonna like blow groceries all over the aircraft." They're like, "No, you'll fly on your first shift." And I was like, "Okay."
Yep.
So I went, they used to take us all out to Denver for like 11 days to onboard us at my first company. And I was learning all this aviation stuff, and I'd never felt more stupid than they were like MSL and AGL and IFR, VFR. I had no idea what any of that meant. So there's another recommendation is if you are looking to get into flight, you will probably help yourself when you get to the interview portion of like the operations interview, if you know a little bit about aviation, which you will learn about if you take our flight medical provider course, right?
Yeah. Absolutely.
So
Now, like I don't look at clouds the same. Prior to flying, I am now always constantly looking at the weather, measuring how high the cloud deck really is. Is it scattered? Is it broken? Or is it solid?
right?
Out and about, I'm like, oh, it's definitely IFR here.
What's the humidity? What is
Mhm.
the dew point? What is the actual temperature and dew point spread? What is the wind, right? I
Yeah.
saw someone that I'm friends with. I have a work Facebook page where I interact with people for work, and then I just have my personal one that's just like family and close friends. But on my work one, there's a ground medic that I'm friends with, and she posted yesterday, I don't ever want to hear you flight people complaining about weather ever again. I just saw an Air-Evac aircraft taking off and it was raining and they were flying in the rain. So I don't want to hear any of you ever cancel on us because there's one cloud in the sky. And I almost screenshotted it to do a post on it about education because, like, I have flown in the rain, I have
Mhm.
flown in snowstorms, and I
Yep.
have declined flights when it's clear blue and 22
Yep.
because it is not just about right now when we are flying.
Yeah.
Our pilots have to anticipate what the weather is going to be throughout the duration of the course of our flight, right? So where are we headed to? Maybe the weather is different somewhere else. Maybe the temp and dew point spread is 2 degrees, right? So when your actual temperature meets the dew point, you're going to have instant fog development if your humidity is above a certain point and you have no winds, right? So we can have a 5 degree temperature and dew point spread. And I've had pilots that refuse to take a flight in there because it's only 5 degrees apart if the winds are calm, if there's no winds whatsoever, because wind is also going to help dissipate that. So there's so much to it. There are sometimes when we can fly in rain. There are sometimes when we can fly in snow, right? It's not often that we can take flights in those, right? It just depends on what the visibility is. If it's a small little rainstorm, we can go around it. I have flown straight through all of
Yep.
that weather before, and there's just so many factors that even now, with 5 years of flying under my belt, there's still stuff that I'm like, I gotta ask the pilot because this is beyond what I
Yeah.
feel comfortable making a decision about. So there's a lot to it that people don't realize. You know, people might talk garbage on us on Facebook or maybe make jokes about, oh, there's one cloud in the sky, they're not going to fly. But then once they get into flight, they're like, oh, I get it now.
It makes sense because it's not just about where the wreck is or the hospital is. It's about the receiving facility. Can you even get there? And that affects my decision. Like if I go to a scene and I know that I have a pediatric trauma, I have two options in completely opposite directions. Well, if weather's coming from this one, I'm sorry you live over here, but we're going over here. Like I'm going in the direction of the closest facility that I can get to. I know you want to go over there, but the weather prevents me.
Yep. There's so many factors that play into it, even so much as a TFR, so a
Yep.
total flight restriction. If there's, I live near Kansas City. If there's a Chiefs game going on, there's a TFR over the stadium. So you're gonna have to talk to ATC and get permission to go around it. If the president is in town, there is a very strict TFR, and you're gonna have to go around things. A lot of times we can get clearance to go through TFRs because we're medevac status. But there's a lot of that stuff that if you don't fly, you just have no idea, right? There might be a NOTAM out for, unforecasted lightning was spotted by, your sister aircraft over here, what have you. There's a lot to it. All right, let's keep going. We already talked about that one. Oh, calling report, doing radio report. Talk to us about that.
Nurses are always on the receiving end of ER, like the reports coming into the ER, and then ICU nurses don't really get this. I can't tell you how many nurses I've seen, and even myself with pre-hospital experience, when you go to call that report, having that concise report that delivers all of the information. You're using letters of the alphabet, but then also having to make sure that it goes with the correct mnemonic, because you can't be like M for mountain and B for boy out there, which, I have been known to say a few things off because now I have a reference card that I always keep when it's 3 a.m. And you're like, what is J again? I can't remember. So you're not giving someone's name over the radio that everyone could listen to, but it's, what do I even say in this report? How do I give report? Who do I even talk to? And what do they care about? So if you're delivering a trauma, they're going to care about, what type of injuries they have. Did they lose consciousness? Have you given blood? What's your access? What's their GCS? What things have you done in flight? Or so that they on the back end can start thinking, what do I need to prepare for? Or what kind of condition are they going to arrive in? Versus an ICU report is what's happening in the aircraft versus what the sending facility told me, because sometimes it is completely different, or
Yeah.
we'll get to a sitting facility and they've painted one picture and then I've had to do a lot of work and change a lot of things in flight, and then they show up on 3 drips that they didn't have beforehand. So that ICU is like, oh, well, now they can't go to the step down unit. They actually do have to go to an ICU and they have to rearrange things.
Hmm.
So
Yeah.
that report is so important to deliver concise information of what you need to know, but it's not something we normally do. Like ER nurses will call up and give a report to the ICU nurse, and the ICU nurse is always mad at the ER nurse for not checking their skin or giving them, well, what were their home meds and when was the last time they ate and all that type of information. The ER nurse, like, just take them. Something's wrong. I just took over for them 5 minutes ago, which is so true. And all I know is that they have a kidney stone and now they're septic. Here you go. So it's
Yeah.
that crossover too of the different mentalities of what you care about, ER versus ICU, and now also in like helicopter EMS or transport world of what does a receiving facility care about and what do they
Yeah.
want to know.
Yeah, I'm going to preach to my ER nurses here for a second. I was actually working an ER shift the other day, and the nurse that was taking report at the radio was asking all kinds of questions where, every ER keeps a binder or a notepad of pre-made forms, where you write in all the information, what unit is calling you in, the date and time, how far out they are, the patient's vital signs, the chief complaint, the age of the patient, gender, all that stuff. There's all these blanks that you fill in. And they were giving report on a patient that, like, the patient was super ill, right? They were going to be a priority one. They were going to go to the trauma bay. I don't remember if it was a medical or if it was a trauma patient. And the nurse is writing down this on the difference. And she's like, what's the GCS? Like, that doesn't matter, right? The reason for radio port is to prepare the receiver for what to have ready to manage that patient in the first few seconds, right? And that helps us to triage that patient. It's unimportant to get these other details. You might have a blank for that, but if I'm telling you this patient requires, I am actively resuscitating this patient, their GCS does not matter. Their blood glucose right now does not matter, because all the point of that radio report is to get the ER ready in that trauma bay to receive that patient. Like, they don't realize that medic is taking care of that patient by themselves in the back of that truck. They're actively resuscitating a patient and trying to answer all of your stupid questions on the radio. So the purpose of that is just to get you ready for what you need to know, right? And as ER nurses, we're pretty darn good at that. So why do we heckle the medics pre-hospital when they're bringing us patients, right? I work mid-shift, so I always am taking over for someone else in the ER. And how I get report is I usually like wave my hand in front of the paper towel dispenser, grab one, and I write down like maybe 4 words for every patient, like room 1, kidney stone, waiting on the CT to come back. Room 2, UTI, waiting on the UA to come back. Room 3, septic patient, they have levo going at 10 mics a minute, waiting on an ICU bed. Done. Clear, right? That's all we need from the medics pre-hospital. And I looked like a certified dummy my first time calling radio report on a patient, because I am used to, as an ER nurse, calling up to you in the ICU and giving you a report on this patient. Okay, they came in today, their chief complaint was this, we did this lab work and we found this, and here's the interventions that we've done, and here's what the patient looks like, and here's what I'm bringing up to you. And it might take me 5 minutes to give that ICU nurse report. I did that over the radio. And when I was like, I got done and I looked at my medic partner, like, was that good? And he was like, don't ever do that again. And I was like, what? He was like, chief complaint, vitals, if anything has changed or if we need help on the pad. And I was like,
Yeah.
Oh, okay. So that was Gwenny's lesson in concise radio report.
Like less than a minute. It's a lot. What is important? What is going to kill this patient, or what do you need to be prepared for? GCS has gotten worse. So we went from a GCS of 15 and now we're at a GCS of like 10. So you might have to be prepared to intubate this patient. I may not do it right now because they're 350 pounds and I can't properly prepare them if I can maintain their airway until I get to you and we can safely intubate this patient once we get there. That's what I'm going to do in flight, because they're at a higher risk sometimes if I do it now versus when I put this 300-pound patient who's got COPD and asthma and, diabetes and all these medical problems, and I can call somebody that have help to do this, position them better to have a successful intubation on the first attempt. So don't give me a hard time if I show up just bagging my patient. As long as as long as their oxygen's good and their CO2 is good, I'm happy with it.
Yep. There have been times where we've had our pilot call report. If we are
You know
so
that's bad.
saturated in the back of the aircraft, if this patient is crumping, especially if it was like a super sick scene flight and we're starting from scratch, you know,
Mhm.
we've had the pilot call report and go, hey, this is the pilot. We're coming in, Air Care 2, and we're going to need some hands on the pad. My crew is busy in the back. We need a cot, and they said they're going to need XYZ on the pad. We'll see you in 2.5 minutes. And they're usually pretty good about meeting us on the pad with whatever we need, and we get all the hands and the help that we need. But sometimes that's what report is. Sometimes it's a super easy report, right? If you pick up an interfacility transport and it's kind of a moderate acuity patient, they're not super sick, right? This is a bulk majority of our patients. We don't have to do a lot for them, right? They're calling us for speed. They're not calling us for our incredible abilities to be pre-hospital providers. But a lot of times we don't have to do a whole lot if they've gotten them appropriately managed at the sending facility. And so we'll call and I'll just say, hey, I'm bringing you this patient, initials Kilo Papa, and they are as advertised. Here's the vital signs. I'll see you in 11 minutes, right?
Yep.
Pretty quick. When you were talking about the military alphabet, I have made all my kids memorize the military alphabet. So my kids are 15, 13, and 6, and they all three know the military alphabet. My 6-year-old, she's still kind of a little hazy on a few of them. Because when I started flying, there were three of us nurses. We were all three the same age. We were all three women. We all three had 3 kids. Like we just had a lot of similarities. But one of the other ones, man, she was such a she was just a little ditzy, was the best word for it. She was super smart clinically, but kind of a ditz when it came to common sense. When she was calling radio report one time and she said the initials are KP as in kittens and puppies. We made fun of her for a very long time for kitties and puppies. And I was like, my kids will never say kittens and puppies. And so my kids know the military alphabet.
That
We
is
tend to
awesome.
practice it in the car, right? Because there's so many applications to needing to know letters, right? If you have a weird last name, you have to spell it out. You can use
All
your
the time.
military alphabet. Anyway, what else? What other topics do we have? Sorry, my mom is blowing up my text message right now. I took my daughter to the Taylor Swift, not the real concert. I'm not quite in that tax bracket, right? We are pre-hospital providers. Hey, if you didn't know this, nurses in the hospital make really good money. Nurses on the helicopter barely make above minimum wage. So
Yeah, you would think that we're going to make more money because you have more responsibility going to the aircraft. That is not the case, my friends. They look at it like this
supply
is
and
a
demand.
yeah, it's a high demand job. Like there's always going to be somebody that wants to fill your spot. So if you don't want to take the pay cut, then sorry. I have so many people who are like shocked when they're like, don't you make way more than these nurses? And I was like, no, my friends, those nurses make good money. I make peasant money compared to them, especially with travel
Yeah.
contracts. Not even
Yeah.
close.
Yeah.
But
That's
it's
another
worth
thing.
it.
A lot of us commute along. What's your commute to your
An
base?
hour and 20.
Mine's 3.5 hours. I get up at 2:45 a.m. I leave by 3 and I get there by 6:30 a.m. for my 7 o'clock shift. So a lot of people really commute a long way. Anyway, all that to say, I took my daughter to the Taylor Swift concert in the movie theater, the one that was recorded, not the actual one. My mom's like, did you have fun? Show me pictures. All right. So I'm reading back on your text now. Work-life balance, 24-hour
Yeah.
shifts. I will tell you, I told you earlier that there were 2 areas that I really struggled when I came to flight. I already talked about one of them. The other one was the culture. I was not used to the culture, and not just 24-hour shifts. When I first started flying, Eva was still just a year old. So I was still in the up all night phase, breastfeeding the baby and up. So it wasn't the 24-hour shifts and the lack of sleep that bothered me. It was the culture, living with a stranger for 24 hours at a time. And the pre-hospital culture is wildly different from the in-hospital culture. Did you
Yes.
experience the same?
I think because I started in fire EMS before I went into it, I had an understanding of it a little bit more. I was one of the only females at my fire department, so it was not uncommon for me to be the only lady on shift. For the different types of cultures that you experience. But I will say that culture is huge, depending on like where you are in your base culture is drastically different. It's not just, it may not be like a company thing. It could be this base is fantastic and 20 miles down the road is another base and their culture is completely different. Their mindset, what is important to them, how they approach things can be very different. And I feel that with work-life balance, when you're away from your home family so much, that having a good base culture can make or break you. With coming to spend this much time away from your family, right? You have to live with these people, eat with these people, be up at 3 o'clock in the morning when you're cranky and tired with these people, and all get along and still execute your job to the top-notch ability. And I will 100% drive farther in order to be in a place that I feel like is almost like home, or this is being, I don't do this job for the paycheck. Clearly, I absolutely love what I do, and the people make it even better. I have great management. I have people here that, we all will help each other out. We all have respect for each other. If there's an issue, we are very direct with each other and try to resolve it. And unfortunately, not every place is that way. If you get into a situation where the culture is not that way, I mean, sometimes it can be difficult if that's your only option. But I just want you to know that it does make a big difference in that home work balance, where like you're like, I can, it's 12 hours, like it's fine. I don't have to worry about working with Betty Sue for, another day, or days normally don't match up. Like you have 4 to 6 providers that you're constantly with all the time. It's not like, hey, can you switch me pods because I don't want to be in this pod? Can you put me over here so I don't have to be around this person? No, you have to work in very close proximity with that person all the time. So culture is huge.
Yeah, it is. And I actually didn't know that the base that I was at had a terrible culture. I mean, I knew that it wasn't fun for me. I knew that I wasn't liking it when I first started flying.
Yeah.
But I kept getting told, like, this is how EMS is. If you don't like it, go back to the hospital and work with the other women that you used to work with. Because the hospital that I came from, it was a level 1 trauma center, safety net hospital, downtown Kansas City. It was a rough place to work, and we all bonded through that shared trauma, right? There's
Yeah.
no bond quite like shared suffering.
Yes.
Like even I've been gone from that hospital for 5 years, and still a couple of my close friends I met working at that hospital. And so we worked really well together. We had a great culture in that ER. And when I went to the base, and there was rampant sexual harassment and just really kind of crummy culture, and I kept getting told, like, this is just how it is. If you don't like it, go back to the hospital. And it turned out that all 3 of those women that I was hired with, we were all 3 struggling, but none of the 3 of us talked to each other about it. All 3 of us were struggling with how poor the culture was, but none of the 3 of us realized that any of the others were struggling too, because we kind of kept it to ourselves. So that is one kind of pointer that I will give you, is if the culture is anything less than what it should be, don't be afraid to try to change the culture. You speak up for yourself. Hey, I'm not okay with you touching my butt because you think it looks good in the flight suit. I am not okay with you making filthy jokes. I'm not okay with you, making racist jokes. We're going to have to change that. So speak up about it. And it may be that base needs a culture change. The company and the base that I fly at now has an amazing culture. It's a hospital-based program. They're just really good people. So I really love where I'm flying at now. And I'm really glad that I didn't let my first experience kind of spoil it for me and give up after that. So yeah, the culture is way different. You're living together for 24 hours, take turns, cook each other meals. We work holidays, make Christmas dinner for each other if you're working. I'm working Christmas Day later this year. And I'm already planning to make, a big meal to share with my coworkers. And it's totally different. It's different than the hospital. But it can be fun. It can be good. So, all right. Any final pointers or anything that you want to share with the viewers for nurses who are either new to flying or looking to fly?
I would say what helped me to guide me in the right direction. A lot of people are like, where do I even start? Go online and see all of the different certifications that you need to fly. Go and look at everyone's different job. I don't care what company it's for. Look at multiple companies, see all the different certifications and skills that they're looking for, and start your process and journey early to educate yourself and obtain those certificates. So that way you are well prepared when you go to apply or get a position. Somebody who's going to show up that has already a lot of different certificates, and you don't have to have your advanced cert like CFRN, things like that before you fly, but most companies require it within 1 to 2 years. But it's getting the knowledge and the expertise. You're going to need trauma, you're going to need all of your ABC cards, so your PALS, your BLS. A lot of places require you to
NRP.
get NRP, things like that, having those advanced certifications and taking any class that you can. And like Winnie said, there's tons of stuff out there. I listen to a podcast on the way to work 3 to 4 times a week. Maybe it's just on the way to work and on the way home, I'm jamming out to my own music to decompress, but I'm listening to something and I'm always constantly learning. When you get into this position, you're never gonna stop learning. And I
Correct.
think that's the biggest thing is you're gonna come across things flying in the hospital, whatever, that you don't know. And it's okay that you don't know. Just be aware of it, own it that you don't know it, and then be eager to say, okay, now I need to know about this so that I can know for the next time and be able to be humble enough to get that feedback. You're gonna get a lot of feedback, hopefully, from whoever you're flying with or learning from. Even when you're working in the hospital, get that feedback to say, hey, is there anything I could have done better? What did I, one thing I did good, one thing that I did terrible? What is my goal for this next time around? Is constantly learning. And if you continue to do that, and we all continue to do that, you're going to continue to be able to then help others as well. Like once you get to the position that you want to be in, don't be that mean girl or that mean preceptor. Like now lift somebody else up because you were that person as well one day.
Yeah, absolutely agree with that. Man, I had my fingers crossed because there was something I wanted to point out and I've already forgot it. Doggone it. It was like 2 sentences ago, and I was like, oh, I'm going to forget that by the time. This is why I interrupt people. I am an
Me too.
interrupter, and I don't mean to, but it's like, if I don't say it right, I'm going to forget it. And I lost
Most
it.
people in our line of work also have raging ADHD or ADD. So just being aware of that.
I
And
go back
it's
and forth between thinking that I have it and that I don't. I'm like, I just sometimes do a poor job of focusing. We were talking about feedback. Oh, that's what it was. That's something I ask every time I transport a patient. When I get to the bedside, I say, what could I do different or better next time? Because sometimes this might not be something better. They just might like them prepared differently, right?
yeah.
And it also depends on your destination. There are some places that really like their patients to be on a heparin drip if you're going to the cath lab. There are some places that prefer their patients to have a Brilinta on board. It just depends on where you're going. So I always ask when I drop a patient off, is there anything you would like me to do different or better next time? And I have learned so many cool things just in that, especially if there's a physician at the bedside. I transported a patient a week or two ago that she was a really sick pediatric patient and she developed pulmonary edema in the middle of our transport. My partner and I were both looking at each other like, she's not a cardiac patient. She doesn't have sick lungs. She was intubated because she's a neuro patient. Why on earth does she have so much pulmonary edema? We were suctioning her constantly, just getting buckets of pulmonary edema out of this baby. And so we dropped her off at the bedside and we were telling the fellow, she was at the bedside, and she said, well, sometimes I see this thing called POPE. It's post-obstructive pulmonary edema. And I was like, but she never had an obstruction. It didn't make sense. And I looked it up on the way home and I was reading about it. It didn't really make sense. And then my partner was talking to the oncoming nurse about it the next day. And she said she was an ICU nurse. So she's all things neuro, right?
Yeah.
And or she's, excuse me, a neuro ICU nurse. And she said, oh, it's probably neurogenic pulmonary edema. And I was like, I'm sorry, it was what? What is that called? And I had never heard of that before, right? And sometimes people
I'm
think
learning about it right now.
because I'm Gwenny from Impact EMS or used to be Gwenny from IMED, people think that I know about all of the things and I don't. So when I go to teach, I always ask students like, hey, if this is your area of expertise and I'm teaching on it, like speak up, teach me about it while you teach the rest of the room. Because as an IC or as an ER nurse and as a flight nurse, I'm a jack of all trades, master of none, right? But you as an ICU nurse, you are a master of certain areas, right? Our friend Sarah, she is an ICU nurse. She works in a medical ICU where she gets a lot of liver patients. She is an expert on all things liver, right? So these ICU nurses tend to come specialized. So she taught me about neurogenic pulmonary edema, and I got on and I did my own reading. Guys, you cannot expect that this is going to be spoon-fed to you. When you work in the hospital, they tell you exactly, they give you your quarterly health stream education and you click through it. Usually we hit play and walk away and then come back and fake it through the quiz, right? Fail it once, write down the correct answers, and then take it again. I know how this works, right? Might have done it myself a time or two. But it is on you now to go out and find your own education and you find for you to go neurogenic pulmonary edema. I've never even heard this. I need to read about it. So I've read probably 10 different pieces of literature on neurogenic pulmonary edema in the last week. So keep on learning, never stop learning. I don't care if you've been flying for 20 years. My best friend has been flying for 22 years, and she will still say, oh my gosh, I've never heard of this, or oh my gosh, I've never seen this. Let's learn about it. And we talk about it. Right. So lots of learning to do. Hey, do you want to talk about the interview process really quick? Because it's way different than the hospital.
It's so different. And it's different depending on where you're at. So I worked for another company, and some places it is very driven on you take a test on certain like information that's pre-hospital related. You might have to interpret an EKG or multiple EKG strips, knowing trauma. So like if you're just an ICU nurse, like expect there's going to be trauma on this test, and that score is going to kind of put you into that application process. Some places you have to pass. Some places it's just kind of like an idea of where you are. We know you're an ICU nurse, you're probably not going to do well, but if you're bombing this test, maybe you're not ready. And that's good feedback that that person can get to go back and continue to prepare themselves for this line of work. And then there's test beyond the test questions, there's interview questions. And sometimes it's not just how good of a nurse are you, but how are you going to fit into our culture? How are you going to be when you're in a tough situation? How do you take feedback when you're out in the environment and there's a situation where someone is not doing the right thing or the right care? How would you address that? Because in our world, in helicopter EMS at least, people have a choice who their provider is. It's not like, oh, you pick up the phone and this is my only option. When you pick up 911, you get whoever shows up, right? In helicopter EMS, they have a choice on who comes. And there are lots of people out there that will say, I'm calling this one versus this one. They're the same distance away because these people are kind to me. They don't make me feel little or like I'm less than. And they always have a smile on their face, or we don't have to fight with them. They just kind of go with the flow, versus this crew comes in and they don't have respect for us. We're doing our best that we can. And that's why we're calling you. And we just need your help. And if they get treated like crud, they're not going to call that service,
Yep.
or they may be in a bigger helicopter, but that doesn't mean, like, maybe we think that we trust these providers that are kind to us and talk to us, that they're going to provide my mom care, because we're serving a lot of us the communities we live in. And I'm going to pick that provider that I'm like, yeah, I know that Christina is going to treat my mom like I would treat my mom. And that's why I'm going to call her service. I know she's trained just as well as these people, but I know maybe she's going to hold my mom's hand and tell her it's okay.
Yep, absolutely. So as a flight nurse, it sounds really sexy and badass, right? Like, yeah, I'm going to go do helicopter EMS and it's going to be awesome. About 10% of your job is going to be patient care.
Yeah.
About 50% of it is customer relations, public relations, going out in the community, interacting with your customers, going out and doing outreach education, right? And then the other 40% is you're doing continuing education, which is never ending in this line of work, right? We already talked ad nauseum how much education there is to do. So very little of it is taking care of patients. So much of it is building relationships with your customers. And the customers are not the patients that you take care of. Your customers are the hospitals and the EMS agencies that call you. And I'm not talking about going and taking swag, right? In our industry, there's a lot of swag. We all hand out t-shirts and keychains and all kinds of stuff with our phone number on it, so they'll call us. But they're not calling us because we brought them pizza and some keychains last week. They're calling us because our ground EMS agencies, especially in these rural areas, they all know that patient. The patient that they're giving you is their neighbor, or that's their, cousins, uncles, brothers, whatever. They are connected to these people and they care about, like, they might wait 10 more minutes to get you on your aircraft because they had a really good interaction with you last time you picked up a patient with them. And they'll say, hey, XYZ base and company is closer, but they were an absolute jerk face poopy head last time I talked to them, or they were really condescending to me, and I don't want to do that anymore. So I'll wait 10 more minutes and I'll get Christina in her aircraft. Mm-hmm. And they'll get you to the scene. So that is so much of it. And now getting back to our original point, sorry, I kind of chased a rabbit there, is the interview process. So I have flown for 3 companies. I flew for my first company for 2.5 years. I left during COVID because I quite enjoy money, and the contracts were high paying. So I went back to the ER to do contracts for about 1.5 years. And then I really missed flight and I wanted to get back to it. So I went back and thought, okay, this will be good. I'll stay with this company for the remainder of my career and retire there. And it just wasn't a good fit for me. The culture didn't work for me, and I wasn't willing to stay at a job I loved in exchange for my peace. So I was like, nah, I'm out. So I only stayed there for 6 months. And then where I'm flying at now, I drive a long way to get to it. Just like you said, I will drive much further to get to a good culture base. But at all three jobs, it all started with kind of an initial phone call, kind of a screening. So when I first started flying 5 years ago, I found a statistic online, and I don't think it's probably still true today just because of understaffing and so many people leaving healthcare during COVID. But for every one open flight position, there are an average of 250 applicants. Now, the vast majority of those applicants are not even close to qualified. And so most of those are easy to sort out right away. But it usually starts with just like an initial phone call with the area manager or a recruiter from the company to figure out, like, do you have all of your ABC certs? Because you've got to have so many to even get an interview. Do you have this much experience? Do you have this many hours in a busy system, right? 5 years at a slow ER, not good enough. You got to go work in the big city and get some high volume experience. So that initial phone call, then it's usually a written test or on the computer test just to kind of see what your knowledge is. And then if you pass that, then you usually go for simulations, right? And I've done the simulations with the medical director, and I've done it just with flight crews. So doing those simulations and watching how you take care of a patient, and they're not just looking for your clinical acumen, they're looking at how you interact with the patient or how you correct things that are wrong, right? How many times do we get on scene and they are ventilating the patient with the worst possible ventilator settings, or they are mashing that BVM with both hands, and probably have popped both lungs? How do you correct that? Are you diplomatic about it, or are you a jerk face poopy head and they're never going to call us again? So they're looking at those things. And then usually the last step is a culture interview where they want to find out what kind of human being you are, right? If someone is a fantastic human being, but they're maybe weak clinically, we can fix that. We can get them more clinical experience. We can get them education. We can train them. But if someone is a top-notch clinician, if they know all of the answers, if they get 100% on the test, they are phenomenal at their skills. They can innovate and throw in a chest tube and crike and all these things flawlessly. But if they are a total clown,
poopy head.
yeah, jerk face, poopy head, we can't fix that. That's not something
can't.
we can fix. And I have seen many great clinicians be turned away from flight jobs because they are a jerk, right? We've got to listen more than we speak, and we've got to be able to be a good team, because the back of the aircraft, when the fecal matter hits the fan, is not the time for us to realize that we don't interact well together. So that's kind of what it also happens very slowly. My ER job where I have now, I applied for it on a Monday afternoon, and I had the job offer signed on Tuesday morning. It happens quickly in the hospital, right? Essentially, if you have a pulse and a nursing license, like, they'll give you a job somewhere. And for this flight job that I have now, it was 6 months long, the interview process and the different phases of it. So
I would just like to add on too, this is also your ability to interview the person or the company that you're going to start at. I understand that everybody wants to get their foot in the door, but if there is a terrible safety culture there, or if you come with questions, please come with questions, because a lot of time you do an interview and no one has questions, and you're also interviewing them. Like, how do they handle a situation? Ask them different things that have popped up, or like, how does this work? Things don't just take the job to take the job, which I know we all want to fly, and it's an amazing career to do, but it's also your chance to interview them, because if you go out and you have multiple interviews, you're going to say, well, which one was the best? And if you haven't asked your questions to see which place would be a good fit for you to be successful and an environment for you to grow in, then maybe that's not the place for you to start, because I have seen a lot of people go and then they get into the wrong base or the wrong culture that they couldn't grow in. They're like, well, I'm done with flight. And it could have just been, you had the wrong base, or they didn't have a good safety culture. And I would hate for anyone to throw away this like dream career because, oh, well, this one time it didn't go well, or I didn't like this first time. Not every single base, company, culture, like, they're all very different depending on where you're at, where you fly, what company it is, who's your program director or base manager or anything like that.
Yeah, yeah, you bring up a good point. At the flight service where I'm at now, they were actually talking about this not too long ago. They were saying that they had, I can't remember if it was a nurse or a medic that interviewed with them, and they said the person interviewed really well. They just wanted them to have a little bit more experience. And so they gave them some feedback and said, hey, go start working at XYZ place, get some more volume under your belt, get a little bit more experience. And we would love to see you back here in a couple of years. And they were excited. They were kind of like had a mental note, like, hey, when that person comes back, we're going to hire them next time. Well, this person was so excited and wanted to get into flight immediately that they went and took a job with a competitor in our area. And now our flight service have said we won't hire them back. Even if they leave that flight service and come to us, we will not hire them back because we know that competing company, we don't agree with how they operate, and now that person is kind of spoiled of sorts, and they've learned the wrong ways to do things, and so they won't hire them. So hold out for the best opportunity. Don't take the easiest yes. So that was really great advice. I'm glad you brought that up.
Yeah.
Well, Christina, thank you so much for your time today. I really appreciate you lending your expertise and your experience to us. And for our viewers, I hope you found this helpful and useful, and we will catch you guys on the next lecture. Feel free to reach out to either one of us. You can find both of us on social media, and or email us at our website. Our email addresses are on our website at impactems.com. So we'll catch you guys later. Take care of yourselves and take care of each other.